Bismillahirrahmanirrahim. Assalamu alaikum. In today's session, we will try to cover two small topics from the diseases affecting the external auditory canal. So let's start today's session. So inflammation of the external auditory canal, that is what we call as otitis externa. There are two main groups which can affect the external auditory canal. One is infective group and the other one is reactive group. And this infective group is again subdivided into different types according to the causative agents which can cause this disease. So if bacteria, they are causing the otitis externa, that can be localized otitis externa, or it can be diffuse otitis externa, or it can be malignant otitis externa. All these are bacterial otitis externa. If the causative agent is some fungus, then we call it as Automycosis. And if viral infections are there causing the viral otitis externa, there are specific entities named as Herpes zoster oticus and Otitis externa hemorrhagica. Then there is another group which we label as reactive group, and it includes some dermatological disorders which can involve anywhere in the body, the skin, as same skin is lining the pinna and the external auditory canal. So these skin disorders can affect the external auditory canal skin as well. So it may include eczematous otitis externa or seborrheic otitis externa or neurodermatitis. Today we will try to cover this Automycosis, which is a fungal infection, and then in second half of the session we will try to cover this viral otitis externa, which is called as herpes zoster oticus. So to start with, automycosis, as you know, this word auto, that is related with the ear, and mycosis, it is specific for fungus. So together automycosis, the word is indicated that this is the fungal infection of the ear. And this is the autoscopic view of the external auditory canal, and here you can see the fungus ball or fungus mass present in the external auditory canal. This fungal infection, it is affecting the superficial layers of the skin lining the external auditory canal, and usually those patients who are immunocompromised or diabetic, they are more prone to get this such kind of infections. And the causative agent, most common causative agent is Aspergillus, and subtypes of Aspergillus is Aspergillus niger, which is black-headed filaments. That is the most common cause. Otherwise, other subtype of Aspergillus, that is Aspergillus fumigatus, can also cause fungal infection. Then Candida albicans can also be a causative agent for this type of fungal infections, or other fungi like dermatophytes can also cause. Usually these fungal infections, they are seen in hot and humid climates in tropical and some subtropical countries. So most common cause, as I told you, is Aspergillus niger. Then in hospital acquired cases, the candidal infection can be there, and those patients who are having sinusitis, in such patients the fungal infection may be due to Aspergillus fumigatus, and other fungi can also involve. Usually the patient gives the history of water entry into the external auditory canal, and this water entry can be accidental, like during taking bath some water would have gone into the external auditory canal, or those who are swimmers or divers and they are doing diving and swimming without the ear plugs, so water can go inside. And when this water gets entry into the external auditory canal, there already the debris are present there, or if some wax is there, that will absorb this moisture, and then this wet material, it is a good you can say growth, good for growth of these fungi. Same happens in rainy seasons as well, and in those areas, as I told you, where there is hot and humid environment. Then if some people are using antibiotic drops, topical antibiotic drops for some other problem of the ear, external ear or the middle ear, they may predispose to the fungal growth. And fungal growth, as I told you, in case of Aspergillus niger, it is filamentous growth with black heads. In case of dermatophytes, that growth will look like wet blotting paper. And in case of fumigatus, as the name indicates, the mass will be pale blue or greenish in color. And if candidal infections are there, then it will be whitish, creamy type of mass present in the external auditory canal. So that gives us a hint of the causative agent for these fungal infections. Though, as far as the treatment or management plan is concerned, that does not make much difference. So the patient will present with intense itching and irritation in the ear. He would not resist this itching, and whatever comes in his hands, he will try to put it inside the external auditory canal. And these may be, keys, these may be fingernails, these may be Q-tips. It can be anything which can be inserted inside the external auditory canal to stop this itching or irritation. Patient will do that, and instead of being relieved, what will happen that he will during scratching there may be lacerations of the external auditory canal, and not only this fungal growth will be more extensive, rather some bacteria may get entry and there may be superadded bacterial infection as well. And so you can well imagine that different types of infections, it will be difficult to deal with later on. So the presenting symptom for automycosis is, our main symptom will be intense itching or irritation in the external auditory canal. Then patient may be having otalgia also, and as this fungal infection will cause some kind of debris or mass present in the external auditory canal, so quite expected is the some type of hearing loss and ear blockage also there. Some ear discharge may also be there, which will be musty odor. And on examination, this external auditory canal will be congested, edematous, red, and it will be sodden. That wet look will be there. And diagnosis is very clear cut on history and clinical examination, but if still in doubt, we can send the ear swab for culture sensitivity, which will show us the growth of the fungus. And if we are suspecting underlying some diabetes, then we should go for blood sugar estimation as well. So this is the autoscopic view, and here you can see the fungal growth or fungal mass present in the external auditory canal. This is the filamentous, different filaments are there, and then there are heads which are blackish in color. Now this is the differential diagnosis of an itchy ear, that if someone complains of that there is irritation or itching, as I told you, and if it is related with the rainy season, or the patient is swimmer, or patient tells that last night I was absolutely okay, then I took the bath and later on I started this itching, so that gives us a clue that it may be a fungal infection. But in addition to that, this itchy ear may be due to dermatitis, that is a skin infection. As I told you, the skin dermatitis can be anywhere in the body, so that, or it may be a part of that generalized dermatitis which can affect the external auditory canal as well. And if some wax is there, dry wax especially, that may also can cause itching, though wax will be brownish or light brown in color, and it cause blockage more as compared to itching, or pain more as compared to itching. But still, some itchy ear may be complained by those patients who are having wax. Then generally, some people, they are having this dry skin overall. So this dry skin also cause itching. So same can happen in the ear canal as well. And similarly, some patients are more hairy. So if some hair are being broken during scratching, and those hair may fall in the lumen of the external aortic canal, and there they may be causing the itching, and simple removal of that hair will relieve this itching and irritation. So treatment is, first of all, a thorough cleaning of the external auditory canal. And this thorough cleaning can be done by different methods which are available. One is what we call as oral syringing. Then if we have got a suction machine, we can use that suction machine with the help of ear tips. At the end of that suction machine, we can suck out all the discharge and that all material which is present in the external aortic canal. And if these things are not present, we can do dry mopping, that we have got in our clinics, this a probe which is called Jobson-Hahn probe. And at the end of that Jobson-Hahn probe, we apply some cotton, very loose cotton, and with that we can mop it out all the external aortic canal. At the end of the day, we have to do the thorough cleaning, which is called oral toilet or ear toilet. Then, as I told you, this fungal infection, it involves the epidermis of the skin, superficial layers of the dermis, this skin, and spores are lying there in between those layers. So if we use keratolytic agents which remove the superficial layers of the epidermis, these spores will be exposed and they will be shed off in the lumen of the external auditory canal, and from there they can be removed by syringing or suction or by dry mopping, and later on we can use the antifungal drops. So one of the commercially available this keratolytic agent is what we call as 2% salicylic acid in rectified spirit. So that can be used. Then commercially antifungal drops are available with the name of nystatin or clotrimazole or dermosporin. So these can be used topically. Then we can use antibiotic and steroid preparation topically, because this steroid preparation, it will reduce the edema, because congestion and edema is there in case of fungal infection. So this steroid which is present in this preparation of antibiotics plus steroids, so it will reduce the edema, and when the edema will be reduced, this antifungal drops, it will easily be accessible to those areas where the spores of fungus is present. And the use of antibiotics is that because when superficial layer is being shed off, there may be small lacerations in the skin, and the bacteria may get entry into those lacerations and cause bacterial infection. So to avoid that super added bacterial infection, these antibiotics will be helpful. So we can use this antibiotic and steroid preparation. Then, as we discussed, that it started with the water entry into the external auditory canal, or it is more prevalent in rainy season or in those areas where the environment is humid. So the main prevention is that the patient should be advised to keep the ear dry. How he can keep the ear dry? He should use a cotton plugs soaked in some oil while taking bath, or commercially ear plugs are available which should be used by swimmers and divers especially, so that they should try to keep the ear dry. And if patient is diabetic, so the treatment of this underlying diabetes control is must. Then we come to another entity which I showed you in the main slide, that this is one of the viral infections which can affect the external auditory canal, and the disease is called Herpes zoster oticus, and the causative agent is virus. And which one is the virus? Virus is that the patient has got, for example, chicken pox, and the causative agent of that chicken pox, that is varicella zoster. Chickenpox has been dealt with The patient is now relieved from that chicken pox, but this varicella zoster, it becomes dormant in the geniculate ganglion of the facial nerve. It remains latent there, maybe for weeks or months, and then later on, by some physical or physiological stress, it became activated. And once it become activated, then it causes the clinical features which we will discuss now. It may involve the ganglion of the fifth or eighth cranial nerve also. So accordingly, there will be the signs and symptoms. The patient will present to you which cranial nerve is being involved. And usually those patients who are having reduced cell mediated immunity, they are more prone to or more vulnerable to get such viral infections. So those patients who are having some, for example, malignancy, and they are on treatment with chemotherapy or radiation, they are usually immunocompromised patients. And elderly patients are, they have less immunity, so they are more prone to, or they are more at risk to get such infections. So what happens basically, as I told you, that varicella zoster virus, it becomes dormant. It latent period is there when it is there in the geniculate ganglion of the seventh cranial nerve, that is the facial nerve. After reactivation, which may be due to some physiological or some pathophysiological factor, it spreads along the sensory fibers of the facial nerve. So the dermatome, the effect will be in the dermatome of the nerve which is supplying there and affected by the nerve, this virus. There will be the eruptions, and then there will be severe pain, which is followed by vesicular eruptions in the distribution of these nerves. There is classification by the Hunt according to the involvement of the nerves which are involved. If only sensory portion of the seventh cranial nerve is involved, then we call it as stage 1. In stage 2, sensory and motor divisions of the cranial nerve is seventh cranial nerve is involved. And in stage 3, seventh cranial nerve plus cochlear part of the eighth nerve is involved. So when cochlear part is involved, then some auditory symptoms that the patient will be having sensory neural hearing loss as well. And in stage 4, the seventh cranial nerve, including its both sensory and motor parts, along with whole vestibulocochlear nerve. That not only cochlear part, but vestibular part is also involved. So there will be a combination of auditory and vestibular symptoms, that the patient will be having sensory neural hearing loss. At the same time, he will be having the vertigo as well. So clinical features, the patient will be presenting in a prodromal phase with otalgia. This otalgia or earache, it will be very severe, unbearable, sharp, and it will be there for 2-3 days, and then it will be followed by rashes, skin rashes or mucosal rashes. So first will be pain and followed by vesicular phase, in which there will be erythematous maculopapular rash, which will lead to vesicular lesions. These vesicular lesions, these will be fluid filled, and this fluid will be watery, transparent. And when this fluid pressure raises, then these vesicles, they will burst, and once the vesicles burst, then they are covered by the crusting formation. Most common site of vesicular eruption is the concha, but other sites like external auditory canal, tympanic membrane, post-auricular groove, and in the oral cavity, the palatal mucosa and anterior 2/3 of the tongue can also be involved. But the most common site of these vesicular eruption is the concha in the pinna. And as I told you, when the pressure of the fluid increases in the vesicles, these vesicles, they rupture, and then there is crust formation. Now, as I told you, this virus is dormant in the ganglion of the cranial nerves. So mostly or usually it is there in the geniculate ganglion of the facial nerve. So usually the patient may present with facial palsy. This facial palsy will be unilateral and it will be lower motor neuron type. So lower motor neuron, unilateral or ipsilateral facial palsy. If eighth nerve is involved, there will be sensory neural hearing loss if only cochlear part is involved, or if vestibulocochlear part, both parts are involved, then in addition to sensory neural hearing loss, patient may be having vertigo as well. And once it has involved the oral cavity, there may be loss of taste if from anterior 2/3 of the tongue is involved. Now this is very important to differentiate here at this stage that what is herpes zoster oticus, what is Ramsey-Hunt syndrome, and what is this terminology which is here, that what we call as Ramsey-Hunt syneherpete. Now herpes zoster oticus plus facial nerve paralysis is equal to Ramsey-Hunt syndrome. I again repeat, Ramsey-Hunt syndrome is equal to herpes zoster oticus plus facial nerve paralysis. So it means that if facial nerve paralysis is not there, but all other features are there, then we will label it as herpes zoster oticus. But during the course of herpes zoster oticus, if at some stage there is facial nerve involvement and that involvement is of lower motor neuron type on the same side, then we will label this as Ramsey-Hunt syndrome. So simply in mathematical terms, Ramsey-Hunt syndrome is equal to herpes zoster oticus plus facial nerve paralysis. In other words, herpes zoster oticus, what it is, that the patient may be having a history of chicken pox, maybe 3 weeks before, 1 month, 2 months before, and now there will be sudden onset of earache, which is very severe, sharp in character, unbearable almost, and it remained there for 48 to 72 hours, and then it is followed by cutaneous involvement of rashes and vesicle formation, and those vesicles formation may be there in the oral cavity as well, so that mucosa can also be involved. So this is herpes zoster oticus, because still there is no facial nerve involvement. But once the face, along with all these features, there is facial nerve involvement, then we will label it as herpes zoster oticus plus facial nerve involvement is equal to Ramsey-Hunt syndrome. In contrast, if a patient is having facial nerve paralysis with previous history of herpes zoster, this chicken pox, now he is having this facial nerve paralysis, but there is no cutaneous or mucosal eruptions. There may be otalgia, but it is not followed by cutaneous or mucosal eruptions. Then we will call it as Ramsey-Hunt syneherpete. So 3 terms are there: herpes zoster oticus, Ramsey-Hunt syndrome, and Ramsey-Hunt syneherpete. So Ramsey-Hunt syndrome, when acute peripheral facial palsy is associated with severe otalgia, cutaneous vesicles which will involve the concha, tympanic membrane, meatal skin, postauricular groove, and it may be associated with hearing loss, dysaceusis, and vertigo if 8th cranial nerve is also involved. So this is a typical case of Ramsey-Hunt syndrome, and in this case you can see that these skin eruptions are there. Some are already healed almost, some are having these black crusts So it means vesicles were there, so those vesicles have been erupted or bursted and the fluid drained, and now these are covered by the crusts. So this is in the healing phase. And in the concha also you can see, and this particular patient was having facial nerve paralysis also on this side. So this is what it is called Ramsey Hunt syndrome. So diagnosis is very clear cut clinically, typical history and typical findings on clinical examination. But if it's still in doubt, we can send this tissue culture for isolation of varicella zoster, or we can go for polymerase chain reaction, that is PCR, which can detect the varicella zoster DNA. Treatment is, if patient has presented to you early, then we can start with the oral steroids. This oral steroids, for example, if we start with prednisolone, it should be in bolus dose for first week, and for next 2 weeks we will taper off this steroid, because the regime for prednisolone, once it is started, this is the principle that we should start with the bolus dose, and in coming days we should taper it off. Suddenly it should not be cut off. So prednisolone in the dose of 1 milligram per kg per day we can start with. So full dose will be for 1 week, and then we will taper it for next 2 weeks. But at the same time we should keep in mind that diabetic patients or hypertensive patients or those patients who are having osteoporosis or other debilitating diseases, they are not good candidate for the steroids, because they will be having severe side effects of these steroids. Mainstay of treatment, because this is a viral infection, so antiviral therapy is the mainstay of treatment, and there are different antiviral agents are available, so anyone can be chosen. So acyclovir, if we choose, we can give it orally 800 milligram 5 times a day for 7 to 10 days. Or famciclovir is available, again 500 milligram orally, but this time thrice daily is sufficient for a week. Or we can use valacyclovir, again orally, but this time 1 gram thrice daily for 5 to 7 days we can use this. And acyclovir ointment is also available. So locally, if these vesicles or crusting is there, we can use local application of these creams as well. Now, as I told you, the presenting feature are to start with, it is severe earache. That otalgia is unbearable, cruciating type, sharp. So not only the routine NSAIDs, these non-narcotic agents, but in combination of those non-narcotic agents, we have to use the narcotic analgesics as well. And not only a combination of narcotic and non-narcotic analgesics, but we have to use these different drugs, because these patients will be having acute neuritis, and which is very painful. So we have to use these amitriptyline hydrochloride or pregabalin drugs along with narcotics and non-narcotics analgesics. If the patient is having facial paralysis, we know that in lower motor neuron facial paralysis, the same side of whole half of the face is involved. So patient cannot close his eye on that side. So we have to take care of that eye. Patient should be instructed to use the iPad. It should not remain open all the time, because that will cause the dryness of the eye, which can affect the cornea, and that damage may be permanent. So the patient should be advised to use sunglasses. Patient should be advised to use artificial tears. So we have to take care of the eye, and at the same time facial muscles are not working. So patient should be advised to go for physiotherapy for the movements of those muscles. Then we can use topical antibiotic plus steroid ear drops locally as well. There can be some sequelae of the disease. That disease has been cured, patient is relieved of its symptoms, but some symptoms may still remain there. For example, post-herpetic neuralgia may be there. and patient may have to use the drugs like amitriptyline later on or permanently. And if facial nerve paralysis was there, and as I told you, if eye care was not proper, there may be what we call as exposure keratitis can be there. And if eighth cranial nerve is involved, in the clinical features we discussed that there can be sensorineural hearing loss. Usually that sensorineural hearing loss is reversible, that once the disease is under control, the hearing of the patient comes to normal, or hearing comes to that level where it was before the disease started. But in certain cases, that hearing loss may be permanent, or there may be partial improvement in that hearing loss. So these may be the sequelae of the disease. So with that, we come to end of today's session, and in next session we will try to cover the multiple choice questions and short essay questions from these topics. If any suggestions or any queries, most welcome in the comments section. Thank you very much.